காண்டி வெயிட் பண்ண முடியாது, சாருக்காண்டி வெயிட் பண்றது. நான் முடிக்க முடியாது, நிறைய இருக்கு.
ஆமா, இது ஸ்கிரீன் தெரியுதா?
ஓகே தான், லைட்டா ஜூம் பண்ணிக்கோ.
ஓகே ஓகே. ஸோ ஃபர்ஸ்ட் breast surgery. First is reduction mammoplasty. Reduction mammoplasty is nothing but reducing the size of the breast. So reduction mammoplasty is the resection of excess fat, breast tissue and skin to achieve the breast size proportional to the body. So the principles of reduction mammoplasty for breast hypertrophy are to improve the patient's symptoms, decrease the volume of the breast, to reshape the breast, to correct the ptosis, to elevate the breast tissue, to automatically correct position on the chest wall, to reposition the nipple and areola, and to reduce and reshape the breast, to preserve the nerve supply to the skin and nipple areola complex, to maintain blood supply to the breast tissue, and to minimize scars. So surgical techniques are described by the location of the block of tissue to which the nipple and areola are left attached. So the pattern refers to incision used to access the different parenchymal pedicles. The pedicle is the portion of the breast tissue preserved with its blood and nerve supply, while the surrounding breast tissue is removed. So the Weiss pattern is the most commonly used pattern. So they haven't mentioned what Weiss pattern is, but Weiss pattern is the most commonly used pattern in almost 80% of cases. Next is inferior pedicle, 59% of cases. Other variants include central, superior, lateral, medial, and doubly attached vertical and horizontal pedicles. So first is the Weiss pattern, 80%. Then next is inferior pedicle, 59%. Then after that, it is the medial pedicle and superior pedicle. Medial pedicle is 19%, superior pedicle is 13.3%.
Actually, so the Weiss inferior pedicle most common. Okay, Weiss na or inverted T approach, inverted T shape incision. Weiss la or idu da inferior pedicle.
Okay. So most common pedicle is inferior pedicle.
Inferior pedicle.
Okay. So most common inferior pedicle, adukaprama medial pedicle, apra superior pedicle. So next one, there is no difference between using a T-shaped scar and vertical scar. So vertical reductions are based on the blood supply to the superior or medial pedicles. So that's the MCQ point. In very large breast or gigantomastia, the pedicle would be too long and there is an increased risk of ischemia and necrosis of the nipple areola complex. Thus, frequently an amputation style technique or a reduction with subsequent free nipple graft is employed. Next, suction assisted lipectomy is used to remove excess fat laterally, and there are small number of patients with mild to moderate hypertrophy, fatty breast, good skin tone, no ptosis, and good breast shape for whom liposuction alone will be enough. So patients for whom liposuction alone is enough is good skin tone, no ptosis, fatty breast, mild to moderate hypertrophy, and good breast shape for whom liposuction is only enough. So next is breast cancer screening. Before doing reduction mammoplasty, if a patient is above 35 years of age, we have to do breast cancer screening. Next, 85% of breast reductions are performed at an ambulatory surgery center or basis with inpatient admission for patients with significant comorbidities. So inpatient only if patient has comorbidities, or else it is a daycare surgery. Then we have to stop the patient for using oral contraceptives 1 month before surgery because of risk of DVT and venous thromboembolism. And if the patient has multiple procedures being done, perioperative chemoprophylaxis should be given to reduce the incidence of venous thrombosis. So next is use of epinephrine on the incision lines. So advantage of using epinephrine on incision lines has demonstrated reduction of blood loss and the need for transfusion. Although no significant difference in the hematoma formation has been found, the use of drain has led to no difference in hematoma rate. So epinephrine injection will reduce blood loss and reduce the need for transfusion only. And use of drains, there is no difference in hematoma formation. The most frequent complication after reduction mammoplasty are alteration in nipple areola sensibility, hematoma, seroma, wound dehiscence, and fat and skin necrosis. So most common is alteration in nipple areola sensibility. Next is mastopexy. Mastopexy is the method which is used to treat breast ptosis. So breast ptosis is described as the downward displacement of the glandular tissue of the breast, skin laxity, poor elasticity, impairment in the facial and suspensory ligament may produce drooping of the breast. So classification of by the position of the nipple areola complex related to inframammary fold. So there is a classification which is called Reginald classification. So Reginald classification, it divides the breast ptosis into 3 grades: grade 1, grade 2, grade 3. Grade 1 or minor ptosis, the nipple position is at the level of the inframammary fold. In grade 2 or moderate ptosis, the nipple is located below the inframammary fold. In grade 3 or major ptosis, the nipple and the lower contour of the breast is below the inframammary fold. Several options are available to correct breast ptosis with mastopexy by breast reduction or breast augmentation techniques. So these are techniques used to correct breast ptosis. The effects of surgery are only temporary and ptosis will recur with the passage of time. So that is important point. So there is no permanent cure for ptosis. It will recur. So next is breast augmentation. So this is opposite to reduction mammoplasty. So in breast augmentation, we will make the small size breast into a bigger one. So this procedure is done to resolve the dissatisfaction that some women feel with small breast, either because the breast never developed to a desired size or because the breast has lost volume after pregnancy. So silicone gel implants were commonly used. So the newer gel implants are thicker, more viscous and cohesive, and tend to stay in place even if the shell of the implant is damaged or ruptured. So previously, if the shell was damaged, it won't stay in one place, it will scatter. But recent implants, even if the shell ruptures, it will remain in one place. Saline-filled implants are silicone rubber shells filled within the operating room. So the advantage of the saline-filled implants are the benign nature of saline, so some flexibility in adjusting the size. So depending on the amount of saline filled, we can adjust the size. Smaller incision because the implants are inserted when empty. The primary disadvantage of saline filled implants are high incidence of rippling or wrinkling of the implant under the skin and deflation. So rippling and wrinkling and deflation are the disadvantages of saline filled implants. So next, perioperative complications are relatively low, with bleeding and hematoma occurring in only 1 to 3% of patients, wound infections in 1 to 2% of patients, and some degree of diminished sensibility of the nipple areola complex in 15%. So most common complication is diminished sensibility of nipple areola complex, same as for mastopexy. So more numerous and more serious and other sequelae presenting after years are capsular contraction, implant deflation, implant rupture, implant displacement. So long-term and more serious complications are all these. So next, smooth implants are used in 90% of patients in US. Smooth implants are more prone to capsular rupture when placed in the subglandular plane. So even the plane of placement of the implants are important. So they may be subglandular, that is below the breast, subcutaneous below the skin, and subpectoral like that. So more when they are placed in the subglandular plane, it is more prone to capsular contraction. So next is the incision options. Incision options and indications vary. The inframammary technique is the most commonly used technique. So next is nipple shields. If we use nipple shield, it has become a common strategy for preventing bacterial contamination during the implant insertion. And no-touch technique with glove change and insertion funnels may decrease the rate of capsular contraction. So no-touch technique is we avoid unnecessarily touching the implant, and glove changes, you have to change the gloves before the implant. Periareolar incision heals without visible scarring. So that is one important point. And axillary incision, if it is given, it will be not visible. So there won't be a visible scar. So it is ideal for saline implants. So axillary incision, there is no visible scar, and it is ideal for saline implants. So the implant can be placed in either subglandular, subfacial, or submuscular planes. So there are 3 planes. The submuscular plane, that is below the pectoralis, gives better superior upper pole aesthetics and better visualization of the breast by mammogram. So any future lump or suspicious of carcinoma, we can easily find out by using the mammogram, and less chance for development of capsular contractures. So all these advantages are there for submuscular placement of the implant. So impaired sensibility of the nipple areola complex is more frequent when bigger implants are used and aggressive lateral pocket dissections are done. So the risk factors for reduced nipple areolar sensitivity are bigger implants and aggressive lateral pocket dissection. So saline-filled implants can deflate through the valve or as a result of damage to the implant shell. So these are the causes for saline-filled implants to deflate. So this occurs in 7% of patients within the 5 years. So that's also very less incidence. So next, silicone gel implants can rupture, but the highly cohesive newer implants may preserve releasing the gel. MRI at interval of 3 years and then every 2 years to after to detect silent ruptures. So silent ruptures we can detect using MRI at a regular intervals. So new and more accepted options with the use of acellular dermal matrix has been used for secondary breast surgery in case of capsular contraction and malposition and rippling and pliability. So if the implants has complicated or it has gone ruptured or rippling has happened, we can use acellular dermal matrix for the second surgery. So next is implant selection. Implant selection is important, and the cohesive detailed patient education about the size is critical aspect of the selection. The surgeon must determine the size according to the height, weight, chest configuration, and breast anatomy. The shape, profile, and the surface texture are another important criteria for selection. So implant profile, it can be normal, intermediate, or higher, and may be used depending on the size of the chest and may aid in achieving maximum volume and projection in patients with narrow chest. So implant profiling used to achieve maximum volume and projection in patients with narrow chest. So smooth implants are more commonly used and related to the more capsular contraction when placed in the subglandular space. So subglandular, more capsular contraction, submuscular is the ideal space. Surface texture implants has been used to reduce the capsular contraction. So among the implants, if we use another type, which is surface texture implants, we can reduce the capsular contraction. So, but the complication of surface texture implants is chronic inflammation and development of BALCL, that is breast implant associated anaplastic large cell lymphoma. It will occur by using surface texture implants due to chronic inflammation. So next, fat grafting to the breast. So fat grafting is also another technique of augmentation. So autologous fat injection is done. So the use of autologous fat graft with efforts to correct soft tissue deformities and facial rejuvenation occurred in the mid-90s. So autologous fat transfer may compromise the detection of breast cancer. So that is one disadvantage. We can't easily detect breast cancer. So next is the role of fat tissue transfer in cosmetic and reconstructive breast surgery will continue to evolve today, used for correction lumpectomy after surgical breast reconstruction. So next is it's used on breast augmentation, breast enhancement with mastopexy, and to correct breast asymmetry due to congenital deformity. So these are all the uses of fat autologous fat grafting. So most common reported complication are fat necrosis, lump, cyst, and capsular contraction. So this is about fat grafting. So next is the breast implant associated anaplastic large cell lymphoma, BAA-ALCL. So BAA-ALCL has been associated with breast implants, and many factors are involved in its pathophysiology, including texture implants, bacterial biofilm formation, immune response, and patient genetics. So these are all the factors associated. So mean age is the 5th decade. With implants having been in place for at least 10 years, the most common clinical presentation is the late peri-implant effusion or seroma 1 year after implant. So this is the most common clinical presentation. They'll be having a peri-implant effusion or seroma. Axillary lymphadenopathy was reported in 10% cases, and axillary metastasis in 14% of cases. So ultrasound is the first choice to use in cases of breast swelling, and it can be used to guide FNAC. So ultrasound guided FNAC, MRI can be used. So next is cytological findings in BAA-ALCL. So cytological analysis in the periprosthetic fluid will show large pleomorphic epithelioid lymphocytes with kidney-shaped nucleus and prominent nucleolus. So large pleomorphic epithelioid lymphocytes with kidney-shaped nucleus and prominent nucleolus is seen in BAA-ALCL. So another thing is CD30 positivity is seen and is expressed on activated B and T cells. So once diagnosis is made, staging is done with PET-CT. So here we use PET-CT. Surgical treatment include removal of the implant, complete removal of any mass with negative margins, and capsulotomy. There does not appear to be a role for sentinel lymph node biopsy. Some patients may have some form of chemotherapy and adjuvant therapy. Patients with more advanced disease should be referred to medical oncologists for further treatment. So only early stage disease, we can do surgery. Advanced disease, only chemotherapy by medical oncology. So next is gynecomastia. Gynecomastia is excessive development of the male breast. It's a common deformity encountered in the adolescents and adult male. The most common cause of gynecomastia is idiopathic. So pathological gynecomastia is associated with cirrhosis, malnutrition, renal disease, hypogonadism, and thyroid disease. Also seen in testicular, adrenal, and pituitary tumors and in lung cancer. So next is indications for surgery in gynecomastia. So this is important. Symptomatic gynecomastia persisting for more than 18 to 24 months in adolescent boys. So straight away we should not do surgery. We should wait for up to 2 years. If it's symptomatic for 18 to 24 months in adolescent boys, we can do surgery. Gynecomastia of prolonged duration that has progressed to fibrosis and gynecomastia in patients with risk for breast cancer. Example, Klinefelter syndrome. So in Klinefelter syndrome, we have to do surgery for gynecomastia because it can lead to breast cancer. But as such, idiopathic gynecomastia is not a risk factor for breast cancer. That's an MCQ. Treatment and addressing of the breast assisted liposuction, skin resection, or a combination of these procedures. Liposuction may be sufficient in fatty tissue accumulation. Open incision techniques in the areola may allow surgical adenectomy. In cases of skin redundancy and ptosis, the inframammary approach with and without nipple areola transposition can be done. So inframammary approach can be done if the skin is so redundant. So common complications are hematoma, seroma infection, just like any other flap necrosis. So breast is over. Next, going on to Yogesh?
Procedure of choice for gynecomastia.
Procedure of choice.
Liposuction.
Okay.
It will come later in the chapter, I guess.
Okay. So next, abdominoplasty. Abdominoplasty continues to be among the most common aesthetic procedures done. So the operation excess sagging tissue through a lower horizontal skin incision.
One second. One hello. கேக்குதா?
விட்டு விட்டு கேக்குது.
இப்போ
okay கேக்குது.
Best plane for placement of capsule. See, I mean implant.
Implant submuscular.
Dual. The classல சொன்னாங்க.
இங்க
dual.
dualனா எப்படி?
ரெண்டுலயுமே பாதி இங்க பாதி அங்க அப்படின்ற மாதிரி.
ஓகே.
வயசுல ஒரு கிளாஸ்ல சொன்னாங்க பெஸ்ட் வந்து டியூவல் ரெண்டு சப் மஸ்குலர் வித் சப் இது.
ஓகே.
கிளாண்டுலர்.
சோ அந்த சப் கிளாண்டுலர்ல வந்து ஆனா ஒரு காம்ப்ளிகேஷன் வந்து there is more capsular contraction sub glandular.
ஆமா, texturedல less capsular contraction but chance of malignancy is there. அவ்வளவுதான். பட் பெஸ்ட் டியூவல்னு அவர் சொன்னாரு. அப்படி டியூவல்னு ஆப்ஷன் இருந்தா டியூவல் போடுங்க, அவ்வளவுதான்.
ஓகே. So next, abdominoplasty. The operation removes excess sagging tissue through the lower horizontal skin incision. Muscles and fascia plication corrects the muscle diastasis. Depending on the amount of tissue to be excised, the procedure can be mini abdominoplasty, paniculectomy, or full or complete abdominoplasty. So there are 3 types. The anterior abdominal flap includes skin and subcutaneous, and the flap elevation goes from the pubic hairline to the xiphoid process of the costal margin. So entire abdomen, the flap has to be raised. The umbilicus may be left attached to the muscle fascia with the creation of a new opening for exteriorization. So umbilicus can be left attached to the fascia. Several types of incisions has been used. So types of incisions are horizontal lower abdominal incision is the most frequently used. Another one is the inverted T-type incision or floor D-Lis abdominoplasty incision. It is used in large resections with greater midline abdominal fullness. So next is corset abdominoplasty, or the eye band has been employed for improved outcomes in massive weight loss patients. So abdominal scars from previous operations should be evaluated and may cause ischemia and necrosis in abdominal flap. No evidence exists with respect to the use of prophylactic antibiotics. However, current standard is to give a dose prior to the incision and every 4 hours during surgery. So that is the current indication. So high risk of complications are observed in diabetic patients with obese BMI more than 30. And most frequent minor complications are infection, seroma, hematoma, wound dehiscence. Progressive tension sutures continue to gain support to reduce the incidence of seroma. So for reducing seroma, we have to use progressive tension sutures. The major complications are necrosis, DVT, pulmonary embolism. Next, use of intermittent pneumatic compression stockings has to be used for preventing hematoma, preventing DVT. Chemoprophylaxis for venous thromboembolism is used in a case-by-case basis. And if the Caprini score is more than 8, then we have to use chemoprophylaxis. So next, body contouring after bariatric surgery. So after bariatric surgery, there is massive weight loss. So the abdominal skin and the subcutaneous will be sagging. So patient will have an abnormal body contour. So as seen in the image, so after major weight loss, the entire skin will become flabby. So for these patients, we can do abdominoplasty. So after massive weight loss, excess skin and subcutaneous tissue that fails to retract hangs from the torso. So like seen in the first image. So the skin redundancy may be painful. It will limit the mobility of the patient and is susceptible to infection in the intertriginous areas. And psychological assessment is important to clear the unrealistic expectations. So first, main thing is we should counsel the patient before surgery. And another important thing is after bariatric surgery, 18 to 12 months, the patient should maintain stable weight. That is for at least 6 months. Patient should maintain the proper weight. Then only we should proceed with surgery. So smoking is a well-known risk factor for ischemic complication. So patient should avoid smoking 4 weeks before surgery. And negative urine for nicotine should be there prior to surgery. So patient should not be abusing nicotine and patient should not be smoking for more than 4 weeks. So to obtain informed consent, surgeon needs to have a detailed discussion with the patient to emphasize the trade-off of permanent scars for improved body contour. So the thing is, patient will be having a lot of permanent scars, but the contour will be improved. So that is the advantage and disadvantage. Complications, same for all the procedures: infection, bleeding, fluid collection, skin necrosis, wound dehiscence, asymmetric scars. So scar is a specific complication for this procedure. Surgery needs to be performed in multiple stages. So upper body procedure can be combined with lower circumferential body lift in patients with BMI less than 30 and a good medical profile. So one stage procedure can be done if the BMI is less than 30 and patient is medically fit for undergoing lengthy procedure. So staging procedures can be planned every 3 to 6 months. So there should be a 3 to 6 months gap between each stage of the surgeries. So coming to the different types of abdominoplasty. First is mini abdominoplasty. Resect the skin below the umbilicus to correct limiting infra-umbilical laxity. So only below the umbilicus, if we do it, it is mini abdominoplasty. Paniculectomy is the functional procedure in which the skin and subcutaneous abdominal tissue is excised to relieve symptoms of intertrigo without addressing the rectus diastasis and without preserving the umbilicus. So paniculectomy, we only remove the fat. We will not address the rectus diastasis and we will not preserve the umbilicus. So abdominoplasty can be performed in traditional way as reverse abdominoplasty. It is a more laborious procedure planned to improve the abdominal contour, fixing the diastasis and a well-concealed scar and natural umbilicus. So we will preserve the umbilicus, we will fix the rectus diastasis, and we will do complete abdominoplasty. So these are the 3 modifications. So vertical abdominoplasty or fleur de lis, that is inverted T-shape incision, is used to correct the epigastric skin laxity and multiple abdominal folds. So upper trunk contouring procedures reshapes the breast using adjacent tissue, fat grafting and implants, mastopexy techniques. So this is always, sometimes it is associated along with the breast reconstruction also. So in some cases, free nipple grafting can be done. Upper back rolls can be excised using bilateral longitudinal and oblique scars. Brachioplasty and medial thigh lift are designed to reshape the arm and thigh. Next, lower body lift procedures. There is one procedure called belt lipectomy that may help to reshape the buttocks. So near the belt area, that is buttocks and all, we do belt lipectomy. So next is liposuction. So liposuction was introduced in 70s and has been used in combination with multiple basic and reconstructive procedures. So it's like a laparoscopic minimally invasive procedure. So special attention must be given to scars and hernia that may be injured during the procedure. So if there is any hernia, it may injure the contents. So we have to be careful. So liposuction can be performed in an outpatient setting or in hospitals with ambulatory setting in office-based facilities. Many surgeons prefer the majority of liposuction cases with patients under GA. So most of the surgeons prefer GA. Tumescent technique was also developed in the late 80s, and the options for wetting solutions are dry, wet, super wet, and tumescent. So it is a method of injecting anesthesia.
Klein solution.
Okay. Klein solution. Jeffrey Klein.
His name given. Klein solution.
Okay.
You also know the name, other name of liposuction, lip sculpture.
Okay. Lip sculpture.
They are given lip sculpture.
Okay. Lipoplasty or lip sculpture. So Klein solution will be used. So wetting options are dry, wet, super wet, and tumescent. So they have not given what is the difference, but just they have given the names. So the Klein solution, it contains lignocaine 35 mg per kg, that is the maximum dose, and epinephrine, which is 0.07 mg per kg, which is the maximum dose, to induce vasospasm, and sodium bicarbonate. So sodium bicarbonate is used to reduce the level of pain. So lignocaine, epinephrine, and sodium bicarbonate. So several types of cannula are used. Blunt tip is used to minimize perforation risk, and smaller cannulas are used to minimize contour irregularities. Deep or intermediate fat layers should be suctioned primarily. So first, the deep layer and intermediate layers should be suctioned. So areas of adherence where there is dense fibrosis and attachment to the deep fascia should not be suctioned. So this is the reason why we have to first remove the deep and intermediate layers, because superficial layers will be adherent. So we should not remove the adherent layers. So if we remove the adherent layers, it will lead to irregularities. So various methods are there: power assisted liposuction, laser radio frequency, and ultrasound assisted liposuction. So they are all the recent advances. They have benefits over the this ultrasound assisted liposuction may offer benefits of coagulating small vessels, rupturing adipocytes, improving reticular dermis, favoring skin retraction and tightening. So next, large volume liposuction is associated with hemodynamic instability, significant fluid shift, and significant blood loss. So it is a major surgery. So suction assisted lipectomy is a useful surgical treatment for several medical disorders. It is a treatment of choice for gynecomastia to reduce the contour under the arms and lateral aspect of breast after surgical breast reduction techniques. So suction assisted lipectomy, that is liposuction, is the treatment of choice for gynecomastia. So next, liposuction is helpful to reduce localized fat deposits in the buffalo hump and on the upper back and lower neck. So also for HIV associated lipodystrophy, it's a syndrome of abnormal fat distribution associated with therapeutic use of protease inhibitors. So we use protease inhibitors for HIV. The protease inhibitors will cause lipodystrophy, abnormal deposition of fat in many places of the body. So all of this lipodystrophy will respond well to liposuction. So complications of liposuction is seroma, hematoma, lidocaine toxicity, fluid overload. Lethal complications are pulmonary embolism, fat embolism, necrotizing fasciitis, perforation of abdominal viscera and organs. So gender affirmation surgery. So gender affirmation surgery, it is an upcoming field. So they have not given much about that. So it includes microsurgery, craniofacial surgery, body contouring, and aesthetic surgery. It is a combination of all. So it is an evolving field. So next, wound and pressure source. So wound definition, it is a disruption in the continuity of the epithelial lining of the skin or mucosa due to several causative factors. So wound healing. So they have given about wound healing, which we have already studied in basic chapters. So just few points. So neutrophils are first occurring during the first 48 hours. Neutrophils will be replaced by macrophages on day 4. And after day 4, fibroblasts begin to appear. second stage of wound healing begins. Next, proliferative phase, fibroblasts produce large quantities of type 3 collagen. So initially type 3 collagen is produced and rich vascular network of granulation tissue all will occur. Epithelial resurfacing from the wound margins to cover and close the wound. So as we know, the wound will start healing from the wound margins only. Next, remodeling phase. It is the last stage which occurs, which may take from 15 days to up to 1 year. So in the last stage of remodeling, type 3 collagen will be replaced by type 1 collagen, which is in the orderly fashion. Type 3 collagen will be haphazard deposition. So what is chronic wound? Chronic wound is any wound which is not healed for more than 4 to 6 weeks. So most common chronic wound is, it occurs as pressure ulcers, which occurs over the bony prominences. So most common chronic wound is pressure ulcer, but most common chronic ulcer is venous ulcer. So I don't know why they are given different two things like that.
Leg ulcer is venous ulcer.
Okay. So overall chronic is pressure sores.
Chronic is pressure sore. In leg, if they ask, it is venous.
Okay, fine. So most common chronic foot wound is diabetic foot ulcer. So they were confused, but somewhat okay. So fourth most common is arterial ulcer. So next is wound assessment. Wound assessment. So acute wound, they're given description of acute wound. Acute wound is the absence of risk factors, may heal uneventfully in less than 4 to 6 weeks. So if it heals before 4 to 6 weeks without any complication, it is acute wound. If it is not healing more than 4 to 6 weeks, it is chronic wound. So other things in this paragraph, they have only given the physical examination and also no specific MCQ points. So next is diabetic wound. So diabetic wound is, it is the main cause of, causes are diabetic nephropathy, autonomic dysfunction and vascular insufficiency. There is loss of protective sensation due to neuropathy and makes them vulnerable to repetitive trauma. So high pressure points or bony prominences are at risk for ulceration. So next, peripheral arterial disease. So peripheral arterial disease is caused by atherosclerosis.
Last line is MCQ. 20% of moderate to severe diabetic foot infection will lead to amputation.
Okay. So 20% of diabetic ulcers will go for amputation. So next, peripheral arterial disease. So atherosclerosis is the most common cause, and the risk factors are smoking, diabetics, and who have hyperlipidemia or hypertension. So ulcer is, as we know in clinical, it is punched out ulcer, and the wound base is pale and surrounded with necrosis or ischemic borders. And then we have to look for the ABPI, Doppler, all those things. Specific MCQ point. Next, venous stasis and ulcer. So the most common chronic leg ulcer is venous ulcer, and borders may show porcelain white scarring. So that's all. The number is 80%. Most common leg ulcer is 80% of leg ulcers are venous ulcers. Next is radiation wound. So radiation wound is, it is because of DNA induced damage by radiation therapy alters the ability of cells to replicate. So that is the pathophysiology. So cells can't replicate, which leads to non-healing ulcer. So infected wound. So infected wound is signs of infection. Here the MCQ point is for culture, more than 10 to the power 5 organisms are found. That is one. And biofilms. About biofilms, the concept is that biofilms is the one which prevents the wound from healing. So what is biofilm? It is a complex glycocalyx which protects the bacteria from the immune system and from antimicrobial therapy. So biofilm can induce a chronic wound inflammation and so should be removed. So only if you remove the biofilm, the chronic wound will be healed. Bacteria can go dormant or metabolically inert and it can be protected by the biofilm. So when conditions improve, bacteria may undergo activation in the planktonic phase, leading to infection and becoming invasive. So when the conditions improve from the biofilm, the bacteria will become activated and it is called planktonic phase, planktonic stage. So next is pressure sores, pressure injury. So pressure sores, the sacrum is the most common area. So 28 to 36% develops in the sacrum and prolonged, followed by the heel and then the ischium. So actually in Bailey, I think it's given ischium, most common.
Yes, Indira Gandhi School, HM, IG. I better to follow Bailey in this.
You have to follow Bailey.
in this.
Okay. So next, prolonged weight bearing elevates tissue pressure above arterial capillary perfusion pressure more than 32 millimeter mercury. So that is the MCQ. If it goes more than 32 millimeter mercury, the capillary refill perfusion pressure, it will impair oxygen delivery to the tissues, favoring ischemia and tissue necrosis. So there is a National Ulcer Advisory Panel classification. It is given in the box. So we'll see the box. So here they have given the different stages of pressure ulcers. So stage 1, before stage 1, there is a stage called suspected deep tissue injury. So suspected deep tissue injury is a purple or maroon localized area of discolored intact skin, blood-filled blister due to damage of the underlying soft tissue. The area may be protected by tissue. It is painful, firm, mushy, boggy, warmer, and cold. So the main difference is that there will be pain in deep tissue injury. But for pressure sore, mostly there won't be pain. So that is the difference between stage 1 and pressure deep tissue injury. So stage 1 is intact skin with non-blanching erythema, that is non-blanchable redness. So darkly pigmented skin will not be visible. So in dark pigmented skin, black peoples, we won't be able to see stage 1. So stage 1 is also, it may be painful, but mostly it will not be painful. So firm, soft, warmer, cooler as compared to the adjacent tissue. Next, stage 2 is partial thickness loss of dermis. So here there is no slough. So that is the differentiating point between stage 2 and stage 3. So there is no slough, partial thickness loss of dermis, shallow open ulcer with a red pink wound bed. So another thing is, in further description, they have told this should not be used to describe skin tear, tape burn, perineal dermatitis, maceration, or denudement. So this classification is only for pressure sores, not for any other type of wound. So next is stage 3. Stage 3, there is full thickness tissue loss. Subcutaneous and fat may be visible, but bone, tendon, and muscle is not exposed. So this is the important difference between stage 3 and stage 4. So in stage 4, bone, tendon, muscle are all exposed. So stage 3, difference between stage 2 and stage 3 is slough. There is no slough in stage 2. Stage 3, there is slough. Difference between stage 3 and stage 4 is visible bone, tendon, and muscle. So stage 4 is full thickness tissue loss with exposed bone, tendon, muscle. So, and another thing is, you can see in the further description for stage 4, it varies depending on the location. The bridge of the nose, ear, occiput, and malleolus do not have subcutaneous tissue, and these ulcers may be shallow. So based on the depth of the ulcer, we should not grade it, because in the malleolus, it may be very shallow ulcer, but it may be grade 4 ulcer. So that is the concept which we have to grasp. And osteomyelitis infection all possible in stage 4 because bone is exposed. Next, there is another last stage called unsalvageable. So there is full thickness tissue loss in which the base of ulcer is covered by slough. So why it is unstageable? Because most of these cases it will be covered by eschar. So only if we remove and debride the eschar, we will be able to stage the disease properly. So again, they are telling this should not be used for any other classification. This is only for staging system is only for pressure sores. So this is the National Ulcer Advisory Panel classification. So what they have given inside only they are telling here also. So stage 1 and stage 2 pressure ulcer can, now going on to the treatment. So for stage 1, stage 2 can be treated with pressure relief, local wound care, and may undergo uneventful healing. So 1 and 2 is very mild. It will undergo uneventful healing. So next is stage 3 ulcer. There is full thickness loss and subcutaneous tissue may be seen. For stage 3 and 4 ulcer, it requires surgical debridement. And for unstageable cases, we have to debride and then only we have to stage the ulcer. So very easy. 1 and 2, just local tissue care, wound care. 3 and 4, we have to do debridement. So next is prevention. Prevention, we have to, as we all know, repositioning of the patient. In Bailey, they will be given 1 point. So for bed-bound patient, they should be turned every 2 hours. And for wheelchair-bound patient, they should be taught to lift themselves up from the wheelchair for every 10 minutes. Like that, they are told in Bailey. So next is pre-albumin levels. Pre-albumin levels needs to be checked, and value of 20 or greater needs to be are needed before planning for coverage. So patient should be having nutritionally good this thing. So pre-albumin should be more than 20 before we plan for coverage. So There is another therapy called maggot therapy. So maggots will eat all the slough and it will improve the wound in some cases. And another solution called Dakin solution, which is enzymatic collagenases, which is used to remove the non-viable tissue. Next is dressing are used depend on the wound characteristic. If the wound is dry wounds will benefit from hydrocolloid and occlusive dressing. Whereas if it is wet, heavy exudating wounds will require alginase and absorbent dressing. So dry wounds, hydrocolloid and occlusive dressing is enough. For exudative wounds, alginates and absorbent dressing is needed. And negative pressure therapy, suction dressing can also be done. NPWV. So next is infection in the presence of pressure ulcers is polymicrobial. So what are the common bacteria? Are Pseudomonas, Proteus, bacteroids, Escherichia coli, Staph and Acinetobacter. So the therapy for osteomyelitis requires surgical debridement, osteotomy and long course of antibiotics. At least 6 weeks we should give intravenous antibiotics, at least for 6 weeks, 1.5 months. So next, surgery if it is infected to drain the collections, to eliminate the sinus tract in the wound, all can be done. So the flap needs to provide padding to the treated area to protect against new wound formation. So again, we should not allow the bony prominence to be exposed. So we should give proper padding with the flap. So free flaps are rarely used in pressure source. So local flaps are only commonly used. The sacral wounds are treated with gluteal flap. Flap from the superior half of the muscles are constructed and moved in the defect as a rotation flap, VY advancement flap, like that. So mostly local flaps and rotation flaps are used. Free flap is very rarely used. So strict pressure precautions for 2 to 6 weeks after flap treatment may prevent pressure necrosis and dehiscence. So for 2 to 6 weeks, pressure should not be there on the flap. So next is going on to the lower extremity reconstruction. So lower extremity reconstruction, soft tissue coverage of traumatic wounds. So coverage of fracture, demands coverage of exposed bones, vascularized tissue after thorough debridement and of the devitalized tissue. So only after thorough debridement we have to give cover. So now they are telling about the Gustello-Anderson classification. So Gustello-Anderson grade 1 is open fracture less than 1 centimeter. Grade 2, 1 to 10 centimeters with moderate tissue damage. Grade 3 is more than 10 centimeters with extensive tissue damage. So grade 3 is divided into 3A, 3B, 3C. 3A is adequate soft tissue coverage of the bones and extremities. Grade 3B is there is inadequate soft tissue coverage. Grade 3C is with vascular injury. So that is the grading. So grade 1 and most of grade 2 can be closed primarily, but larger grade 2 and most of grade 3 will require advanced reconstruction techniques. So that is the treatment criteria. So early coverage of exposed bone, tendon and neurovascular structure decreases the risk of infection, osteomyelitis and all. So here this diagram they're showing pressure source which is being covered by local gluteal rotation flap. So next is earlier bone healing and reduced infection rate have been demonstrated if the coverage is completed within 72 hours. So within 72 hours, if we do cover, there is reduced infection rate. So that is one one value. And fracture stabilization. Others have shown comparable results if the wounds are closed 15 days after injury, or else we have to make the wound ready and after 15 days of injury we can cover. So either within 3 days or after 15 days. So for many years, the muscle flaps have been the use of choice for traumatic lower limb defects. Gastrocnemius and soleus muscles are accessible as local flaps to cover the upper and middle third of leg. So for upper and middle third, gastrocnemius and soleus flap. And smaller muscles like tibialis anterior, extensor digitorum longus, peroneus brevis can be used for more distal small defects. So for upper, gastrocnemius and soleus, for distal, tibialis anterior, extensor digitorum longus and peroneus brevis can be used. For large defects of the middle and distal third of leg, ankle and foot, microvascular free flap can be used if the defect is very large, if it can't be covered by local flaps. So lower extremity reconstruction has flap failure rate of less than 10%. That is 1%. Then the use of negative pressure wound therapy has allowed for delay of definitive flap coverage. So negative pressure wound therapy can be used, which will delay the definitive flap coverage and makes it possible to close previous large wounds with local flaps. So it will reduce the size, and after reducing the size, we can cover it with local flap. So traditional local flaps include reverse sural keystone flaps have also been decreased for the need of has decreased the need for free flap. So by using these local flaps, free flaps have been reduced. So keystone flap is I referred from internet. So there are two VY flaps in the opposite direction. So that is called keystone flap. So it is used in lower limb. So next is skeletal reconstruction using autologous bone graft, vascularized bone transfer, and Ilizarro technique for osteosynthesis. So bone grafts are generally delayed for approximately 6 weeks. So only after 6 weeks we have to use bone grafts. So alternative to delayed bone grafting is immediate one-step reconstruction of the bone and soft tissue with osteocutaneous free tissue transfer. So using free flap, we can do one-stage reconstruction. So that is alternative, or else we have to wait for 6 weeks. So an important element in considering primary amputation is disruption of the sciatic or posterior tibial nerve. So we should not disrupt the sciatic or posterior tibial nerve. Laceration of the posterior tibial nerve and plantar surface is insensate, which results in predictably in recurrent ulceration, infection, and osteomyelitis. So because the plantar surface of the foot sensation is gone due to posterior tibial nerve laceration, it will lead to recurrent ulceration and infections. So another thing is this ischemia time. So ischemia time longer than 6 hours and pre-existing severe medical illness. So all these will lead to severe injury and maybe lead to amputation. So next is mangled extremity severity score, MES. So it is a score which can be used to know whether we can do amputation or we can preserve the leg. So score is used widely, but should not be the sole criteria for which amputation decision is made. So I think the value they are not given here. Value is actually 7. So if it is less than or equal to 7, we can preserve. More than 7, that is 8 onwards, we should amputate. But only this score should not be used in making decision for amputation. It should be multimodality approach. So replantation of the severed lower limb is rarely done. So digits we can replant, but lower limb, entire lower limb, we can't. So next, groin and thigh area reconstruction. So defects of the thigh and groin are commonly managed with local flap due to high vascularity of the available local soft tissue. So groin is the most common site of distal extremity prosthetic graft infection, because groin area is mostly infected area, so easily it will get infected. So several muscle flaps are useful for coverage of the femoral vessels, including sartorius, gracilis, rectus abdominis. Sartorius muscle is used as the first line. So to cover femoral vessels, if it is exposed, first line is sartorius flap. So muscle originates on the anterior superior iliac spine, inserts in the medial condyle of the tibia, and has segmental vascular supply. So like we saw in the first Matisse-Nahai classification, the sartorius muscle has lot of segmental blood supply. The muscle is mobilized by dividing the origin and proximal vascular pedicles, which frees the proximal end, which can be transposed medially and sutured to the inguinal ligament. So that is sartorius flap. So next, there is higher incidence of infection and dehiscence after limb sparing surgery in the thigh and groin than in the distal parts of the lower extremities. So they're saying even more than the lower extremity, distal extremities, the proximal thigh and groin have more incidence of infection. So local flaps options are gracilis, tensor fascia lata, vastus lateralis, or fasciocutaneous flap as the medial thigh, lateral posterior thigh, and anterolateral thigh flaps. Next, there is VRAM flap. VRAM flap is it is actually VRAM flap. I think is rectus abdominis. So they have not given the
rectus abdominis thing.
Vertical rectus abdominis muscle flap. So it has been promising in 9.4% incidence of post-operative wound complication. So there is only less post-operative wound complication with the vertical rectus abdominis. Next, tissue coverage of knee, leg, and foot. So knee, leg, and foot, pedicled, medial or lateral gastrocnemius muscle flap based on the sural artery. So that is used. So sural artery is the artery for medial and lateral gastrocnemius flap. Next, as a result, one head can be detached from the Achilles tendon independently and transposed with its robust blood supply and vascular drainage without impairing foot dorsiflexion. So it is the main dorsiflexor, it is the gastrocnemius. So only one head can be used for a flap. If you use only one head, the dorsiflexion won't be affected. So which head we will use, medial or lateral? So medial is the longer head and it is preferred. So free flap is rectus abdominis and latissimus dorsi flap has also led to high rate of salvage. So next, so they've given proximal tibia. The most common used is gastrocnemius and free flap. Middle tibia, we use soleus, gastrocnemius, extensor digitorum longus, tibialis anterior, keystone flap, and propeller flap. So propeller flap, it's also referred from Indrich. It is a flap, island flap that reaches the recipient side by axial rotation. So it's like a propeller fan. So we have to do axial rotation and it will reach the recipient side. So these are all used for middle of the tibia. Next, distal tibia. Distal tibia, we use peroneus brevis, extensor brevis, distal based soleus, reverse sural artery flap, lateral supramalleolar flap, dorsalis pedis, faciocutaneous flap, and free flap. Next, for foot we use flexor digitorum brevis, abductor hallucis, abductor digiti minimi, reverse sural flap, medial plantar flap, lateral calcaneal flap, and VY advancement flap, and tissue transfer. So local flaps are often unreliable in treating distal third leg wounds due to its limited reach. So mostly it is difficult for the local flaps to reach the distal end of the lower limb. Next, the area is vulnerable to injury because distal portion of leg has poor skin elasticity. So that is also an important point. So for larger defects, reconstruction in the distal third of the leg relies on free flap. So making anastomosis to healthy recipient vessels outside the zone of injury has to be done. So highly versatile perforator flap allows soft tissue reconstruction without the need for microvascular anastomosis. So if perforator flaps, there are a lot of perforators, even without microvascular anastomosis, the flap will be taken. So large soft tissue defect of the lower leg, free tissue transfer currently remains the standard for reconstruction. So for various parts, basically thing is for proximal lower limb, we have to use local rotation flaps. Distal lower limb, foot and all, mostly we have to use free flap. So that's all.